There's a new game changer in motor speech assessment, the Colorado Motor Speech Framework. It's free, fast, and yes, there's color coding. Want to know how it works and why it's about to become your go to tool for motor speech disorder assessment? Stick with us, you don't want to miss this. Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach. Today, I'm excited to be joined by Dr. Allison Hilger, an expert in the area of motor speech disorders. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Allison, I am so happy to have you here today. Why don't you get us started by telling us a little bit about how you're involved with not just motor speech disorders, but also something special on our agenda today called the Colorado Motor Speech Framework.
Yeah, I'm so happy to be here. So, I'm an assistant professor at the University of Colorado Boulder, and I direct the Colorado Motor Speech Lab. So, my lab broadly investigates dysarthria overall, with a specific focus of prosody and dysarthria because it's so hard to treat prosody. And that's a long term goal outside of what we're talking about today is to develop a prosody treatment program. But I've had a side project that's kind of taken off in the past couple of years called the Colorado Motor Speech Framework, which is an assessment tool for motor speech disorders, mostly dysarthria. I have a couple speech therapists who work in my lab, Kylie Dune Platero and Caitlin Cloud, who have both worked in acute care and just found it was so hard to do diagnosis of motor speech, especially in a fast paced setting. And they came up with the idea of creating an assessment tool. The three of us got together in 2022, and now we have it. It's started in 2022, and 3 years later, it's grown so much.
Yes, I can personally tell you I loved it when you started it, and I'm excited to talk about where it's at today too, because it just like blew my mind when I found out like where you're at now. So let's go ahead and start just by talking about that difficult piece of motor speech assessment. What did you notice? And like you and your colleagues that you mentioned, like what did you guys think about motor speech assessment? Like where it was like, we really need something different available to us.
Mhm. Yeah, and so, you have 2 aspects. You have what speech therapists are currently using, and then you have what's being taught in graduate school. And so what speech therapists are currently using is a lot of informal evals. So maybe I've heard of this a lot. Maybe their hospital has their own informal, like, oral mech eval, or they made one in grad school, or they have one that's passed around, and they're very informal. They go through maybe the cranial nerves, have some areas for observation. So that's, I think, what majority of SLPs use. In graduate school, we do teach on some standardized assessments like the Differential Dysarthria assessment. Um, and there is like the sentence intelligibility test and things like that. But they're expensive and they still don't really allow, like, none of these tools really give you the ability to do differential diagnosis. Differential is supposed to do that, but it's confusing. It's not super easy to do. And so that is where this came from was, we need something that takes all of our observations of speech and non-speech behavior, and then that allows us to match those observations onto dysarthria subtypes or apraxia of speech and start giving us the ability, just a tool to look for those patterns. And that really hasn't been available at all.
Definitely agree. Yeah, I know, like, what I've seen is, like, just, like, people are doing kinda like the oral mech exam, and then but it doesn't, like, lead anywhere, right? And it's just like, "Okay, what is that telling us?" Like, their tongue isn't working and it's just not as comprehensive as now kind of what you've put at our fingertips. So, um
Exactly. Yeah, I mean, and even an oral mech exam, if they have a flaccid dysarthria and a lot of cranial nerve difficulties, that's very informative. But if they don't, like let's say they have ataxic dysarthria and no cranial nerve abnormalities and not really any oral mech abnormalities, what is that really telling you? And then SLPs are relying on their memory of, okay, what speech features associate with what dysarthria subtypes? And it's such a cognitive load to try to remember all that at the same time.
It really is, yeah. So, the this I can tell, like, the place you came from because probably like me, a lot of people listening are like, "Yes, it is so hard," but we all have these productivity standards, and so I
Mhm.
can also sympathize why people are doing quick tasks.
Yep.
So you got this idea, and I know starting new ideas is not a quick endeavor. So I'd like to just hear like your steps of the story. So you had an idea. What research was available, or what were the steps you next used to create the Colorado Motor Speech Framework?
Yeah, definitely. So Kylie, Caitlin, and I kind of dove into the literature. There's not always a ton of literature available. Joseph Duffy has done an amazing job at compiling a lot of literature in his textbook, Motor Speech Disorders. So we relied a lot on his compilation of literature and then also looked at things. And so first we had to come up with what features, what speech and non-speech features we wanted to include, what are the most salient, and also what are the ones that are most applicable to treatment.
Mm.
And then we had to figure out how to organize the tool in a way that was, like, visually easily interpretable. So that kinda led us to the format it's in now, which is, you have the top 2 rows. One shows the neurological area very, broadly, like upper motor neuron, lower motor neuron, basal ganglia, things like that. Then the dysarthria subtype plus apraxia of speech, and then the left-hand side has those features, and in the middle, it has, X's and double X's saying how those features relate to the dysarthria subtypes. And that's kind of where we started. It was all in Excel, like an Excel spreadsheet with a plan of people would print it out and circle it and maybe use their own highlighters. Then we learned how to use macros in Excel that where you click on it and it would change colors. And then, I thought people don't like Excel. We need to get out of Excel. So I found this amazing computer programmer here at CU Boulder. He just graduated. He was a senior, and Frederick Lynn, and so he helped put it into website format where it is now, which I think is so much more accessible and easy to use.
Yeah, I agree. It looks fantastic, and it kind of feels like it matches, like, how we're thinking, and feels really intuitive to just go through and do some clicks. So,
Yes.
um, awesome. Like, what a cool story about teamwork, and, like, you don't always have to start at, like, the perfect thing, you just got started with it and
Yes.
then kinda did the next thing.
Yeah, exactly. It was a lot of brainstorming. And this tool isn't something where we came up with all this on our own. It's more of like a reorganization of what's already out there, the literature and even how other tools are formatted, trying to think of what's the most accessible, intuitive organization to match the features onto the dysarthria subtypes.
Yeah.
And so yeah, it was just a lot of us meeting and throwing ideas around, building it, taking features away, adding features in, adding X's, taking X's out.
Mm.
And then even since then, I've received numerous emails from researchers, clinicians who said, why isn't there an X in this box or a double X in this box? Or I don't understand this feature. And so we've modified it with that feedback as well.
Mm. Awesome. Yeah, I like, how because you put it all, like, under those dysarthria subtypes, it makes it feel less like an island where it was like, "Okay, I separately am looking at cranial nerves. I separately am looking at the subsystems of motor speech. I'm separately looking at intelligibility." Like, it all fits together in a way that I think that we needed someone to organize it like that.
Yeah,
So,
exactly. I teach motor speech for our graduate students here at CU Boulder, and I teach both Joseph Duffy's book and Kathy Yorkston's book. And both books talk about how diagnosis is kind of like finding the pattern in all the noise. There's so much overlap in the features across Dysarthria subtypes. You're trying to find the pattern. It's like, oh, these subtypes all have slow rate of speech. But if there's slow rate and strained vocal quality, then it's probably spastic. So just trying to find that pattern. But again, it's so hard to find the pattern unless you have a tool that
yeah,
shows you what the pattern looks like.
right.
And so, yeah, putting it all together, like you said, not compartmentalizing it by rate of speech, vocal loudness, but all together so you can see how all these features line up.
Yeah,
So much more just user friendly.
that's awesome. I also like that how you phrased it like that. It's like finding the pattern because I hadn't really ever conceptually realized before how much overlap there is between all the different subtypes. It's not like, oh, they have this one thing, so it must be this. So, and I think your tool highlights that in a good way.
Yeah, definitely. And I think that's where a lot of SLPs get tripped up is trying to think of, oh, what is the one thing that would tell me this person has hypokinetic dysarthria or ataxic? And there's so much variation,
Yep.
patient to patient. Patients don't really fit into this textbook,
Yep.
nice characterization. So instead, yeah, looking for the pattern among all these features, even some of the features that overlap quite a bit among subtypes, is going to be
Yeah.
much more effective.
That's wonderful. So let's then, for people listening, get into all the details
Mhm.
about the actual framework and how it's used in clinical practice. So, just in case someone has not heard of this yet, how can people access this tool?
Yes. So it is available on a free website called cmsf.info. So you go there, the first page has instructions, and then you click on the CMSF tool tab, and that will take you to the tool. One thing I will say about the tool is our website does not like save any information, mostly because of HIPAA or things like that. So be careful not to refresh the page as you go through it. It's meant that you fill it out and then you right click it so that way you can save it as a PDF for your records or for the patient's records. So be careful of that. Again, I want to just really emphasize that we're not collecting any information
Yep.
about what's being on there. So you'll get to the tool, and as I mentioned before, the top two rows show the dysarthria subtype plus apraxia of speech, and then the general neurological area that it goes along with. And then the farthest left side column has the category of the feature, so rate of speech, vocal loudness, vocal quality, things like that. And then the next column has the specific features in that category. So in rate of speech, you have slow rate of speech, fast rate of speech, variable rate of speech. And if you hover over, there's like a uh, blue information mark. If you hover over it with your cursor, it'll give you suggested tasks to do. Uh,
Oh, I don't think I know this.
oh, yeah. I should probably make it a little bit clearer in the
That's
tool.
amazing.
Yes. The
Cool. Yeah,
suggested
like,
tasks.
so if someone's, like, looking like, "Oh, I don't know that I looked at this feature," they can just hover and, like, here's some ideas of how you can look at that.
Exactly, and they're suggested. So
Yeah.
this is not like a standardized protocol where you have to follow what we have to the T.
Yep.
And we do that because, again, people are in really fast paced settings and you may not have time to do every single possible thing. In research, for example, I want to do connected speech. I'll have people do spontaneous speech, passage reading, picture description. But in acute care, no, you have to kind of choose what
Yeah.
connected speech you could do really quickly. So, you can choose what tasks you want to do that will inform these features. But the main thing is that you are observing these features and you click on them as you identify them. So, yeah, if they have a slow rate of speech, you click on that. If they have a strained vocal quality, you click on that. If they have equal and excess stress patterns, you click on that. So, you click on the features as you observe them. And as you click on them, there are boxes that are underneath each dysarthria subtype that are highlighted. If it's a double X, it means it's a highly distinguishing feature. If it's a single X, it means it's common for that dysarthria subtype. If there's a minus sign, it means you would not expect it for that subtype. And if it's just blank, kind of means that, again, you wouldn't really expect it. And so as you go through and click on these features, you can see how these features line up with the dysarthria subtypes. Is there one subtype where there's a lot of like highly distinguishing features or even just a lot of common features? And so that gives you a clue. At the very bottom of the assessment, you can actually click to hide any unchecked rows, and that way it gives you a better visual. And then after that, there are some questions about intelligibility, naturalness, efficiency, patient self rating. And then after that, there is also a count of how many X's, double X's per dysarthria subtype, which I do want to issue a word of caution that you do have to use your clinical expertise. This is there to help you. Like, let's say there are 11 marks for hypokinetic dysarthria and like 2 marks for everything else. Like maybe it's a clear hypokinetic dysarthria, but sometimes it's not clear and you really have to use your clinical judgment looking at the features and how they line up.
Yeah, I love that you built that in, that it's, like, responsive, so after you do your clicks, it's like, "Okay, what's it looking like?" But also
Yes.
just from using it myself, I was like, "Oh, wow," like, I kind of thought it would be like everything wasn't under just one subtype, but it is like, there is a little bit of a variety like we talked about.
Yep.
Um,
There's so much overlap. And I think that adds to the challenge of it all, like, imprecise consonants. Every dysarthria subtype has imprecise consonants, and we still include those in the tool because they're helpful for treatment, so
Mhm.
helping to identify treatment goals, but they're not gonna be helpful for diagnosis. So, it again, you might click on that and all the dysarthria subtypes are highlighted, but then at the very end, you look across all the features you've clicked, you're gonna start seeing some patterns.
I like that. So, when we're thinking about using this tool in clinical settings, are there like certain clients or even like clinical settings that you have in mind?
Definitely. So, really, this tool can be used at this point with anybody you suspect having some sort of motor speech impairment. The kind of basis of the tool is to just allow SLPs have something to document their observations of speech. So even if you're not interested in a dysarthria diagnosis and you just want to document what you're observing, you can just do that. You don't have to make a diagnosis. So in that idea, it can be used across populations, children, adults, schools, hospitals, but I think where it's gonna be most commonly used is a medical setting, acute care, rehab, outpatient, inpatient, and a lot of the literature for this tool is based off of adults,
Mhm.
so that's where it's most applicable to, especially adults with neurodegenerative diseases like Parkinson's, spinocerebellar ataxia, ALS, but it could be helpful for stroke, so a lot of those adult-based disorders. However, we are doing another study with children with acquired motor speech to see how applicable it is to them. So I encourage SLPs, don't feel limited to use this tool in whatever setting you're in. Use your clinical judgment. For example, breathiness is common in children and is often a typical quality in children. So that may not be a helpful feature for identifying motor speech in children. So use your clinical knowledge, but again, it's a tool to help you document your observations.
Yeah. Yeah, and I like that it's not like you really can use it the way it's a tool to support what we already know, what we're already trying to find out. So, if it doesn't
Exactly.
make sense to comment on a part, that's fine. Like
Exactly.
we can use it the way we need to use it. Yeah,
Yep.
it was
Exactly.
really thought through in a good way. So, when you are like envisioning an SLP using this in an assessment, I just kind of want to walk through the clinical flow of like how, like what they would do and then how it might impact things. So, can you talk us through what you
Yeah.
see it looking like for an SLP using this tool in the assessment?
Definitely. And at this point, I've used it quite a bit with my research participants. So I'm gotten into a bit of a rhythm as well. So what I do is, the first thing we do often in assessments is a case history. So we get patient in, we're talking to them, confirming maybe what's in the medical chart, asking them about their history with their condition. And starting there, the patient's talking. That's connected speech. So start making observations. So you can have a tab open with the CMSF and start clicking on what you're noticing. How is their rate of speech? How's their vocal loudness? How's their vocal quality? So start making those observations as they're talking. Then you get through the case history, and you may have another assessment you need to do first, or you may want to just do your motor speech assessment next. So it's up to you. And again, as long as the patient's talking, you can always pull up the CMSF and make those observations. But if you wanted to do a motor speech eval next, pull it up. You may want to do another connected speech sample, maybe ask them, what's a typical day look like for you? Or pull up a grandfather passage. And then if you wanted to follow our suggested tasks, you would go through them. And there are very common things like maximum phonation time, some word repetition, sentence repetition, and then DDK, and then an oral mech exam. So very similar to what you've been doing already in a lot of motor speech assessment. It just guides you through those tasks and what features to observe. So that would be you do your motor speech assessment, and then whatever other assessments you're doing next. Maybe apraxia battery for adults, maybe an aphasia test. So it kind of fits into that stream of what you're already doing in your assessments.
That's wonderful. So, okay, I know I'm not the only SLP that's going to think this next question, so I'm going to say it, but I also, as a researcher, I'm kind of like, oh no, you might be mad about me asking this. So, the topic is this idea of differential diagnosis. So, I know that, because I've worked in a lot of clinical settings, like, I just know some SLPs kind of have the attitude of, like, what's the point in doing differential diagnosis? This person has dysarthria and we don't need to know anymore. Um, so I will say, I think something that's really cool about the Colorado Motor Speech Framework is it's just baked in. And
Mhm.
so why wouldn't we do that?
Yeah.
So I'm sure someone's asked you this before, or do you ever discuss this in your grad school class? Like,
Mhm.
why do we want to consider doing the next step, not just calling it dysarthria, but
Yeah.
why do we want to really think about differential diagnosis?
Yes, that is a really, really good question. And I think it's a big question right now in the dysarthria realm is, do we continue with this Darley Aronson Brown framework, or do we kind of abandon it? Do we rethink these dysarthria subtypes? I personally love them, which is again makes sense as we made this tool. And so I'll talk about why I think we should do this arthria subtyping, and also why it's been unreliable in the past, and I think we can improve reliability in the future. So why we should do it? Well, it can help quite a bit with differential diagnosis of a neurological disease, adding information to the medical team. So if the patient, a lot of neurodegenerative diseases do not have genetic testing. So things like Parkinson's uh, Parkinson's, multiple system atrophy, progressive supranuclear palsy. They are diagnosed symptomatically, and they often have similar presentation. And our dysarthria assessment could help with that. We can't make a diagnosis. I can't say, oh, based off of my speech assessment,
Right.
this person has multiple system atrophy. No, but we can add to the information. So, for example, a Parkinson should have a pure hypokinetic dysarthria versus multiple system atrophy often has a mix, either ataxic hypokinetic or I think it's spastic hypokinetic. And then progressive supranuclear palsy also has a mixed dysarthria. So, for example, let's say a patient has a diagnosis of Parkinson's, and you notice that they have a mixed dysarthria. Like there are some strong ataxic features. Informing the medical team, informing the neurologist, they look into it more and maybe they change their diagnosis, which does happen. Patients often go through like 10 years of changing diagnoses. And so it can be helpful in that front. Another area is, a patient comes in again, a diagnosis of Parkinson's, but you're noticing maybe some upper motor neuron symptoms like a spastic dysarthria or unilateral upper motor neuron. And you could be the person that notices that, tells the neurologist, and they find out that the person had a stroke, which I've heard happens
Yeah.
clinically.
Yeah.
So it gives more information about what's going on. Some SLPs argue that we don't need those specific dysarthria subtypes. You can just talk about what part of the brain's affected, like dysarthria from upper motor neuron or dysarthria from basal ganglia. But, for example, there are two types of basal ganglia dysarthrias. You have hyperkinetic and hypokinetic. So I like these dysarthria subtypes. I think they're very related to our field. Um, so I think they do provide interesting information. So that's my framework.
Yes.
One of the critiques of dysarthria subtyping is that it's so unreliable. There's a lot of research studies that have shown that SLPs cannot reliably do this. My argument for that is that we've never had a tool that's allowed them to do it. People have been
Yeah.
going off of their memory, and they listen to someone and they're just, again, like thinking about what features are associated with this subtype, and they just come up with it based off of knowledge and memory. I'm curious, and this is some of our next steps, are to do reliability testing with a consistent tool in front of you that guides you through how these features line up. I think it could improve
Yes.
reliability.
I 100% agree. I feel the same way. Like, if we are expecting people to do this only just from our brains, like, we have so many things in our brains as speech pathologists, like, it makes sense why that would be too much.
Yeah.
And I also have seen kinda like clipboard cheat sheets that are, like, so simplistic, it actually doesn't totally match up with, like, how you've developed this tool, which shows, like, just the broader presentation. So I feel like that also is kind of a disservice if we're just trying to, like, do, like, a one-to-one correlation. So
Exactly. At the very minimum, so let's say you're an SLP who doesn't like dysarthria subtyping, doesn't want to do this. At the very minimum, it helps you be pretty precise about what you're observing, which you can write up. Patient presents with these features.
yeah.
Are they consistent or not consistent with their neurological diagnosis? And then it helps you with treatment goals afterwards. So I think at the very least, for motor speech assessment, we should be much more specific with what we're observing across all these domains,
Yep.
and this gives you that tool.
Yep. That's awesome. So I am a big, kinda like holistic life participation approach person, and so I just
Yes.
wanted to take a minute to shout out the bottom section on the Colorado Motor Speech Framework because I like that it also is helping us build in just simple quantifiable measures
Mhm,
for things like the patient self-rating, naturalness, efficiency, and intelligibility. So we
mhm.
kind of have that nice full picture.
Yes.
um, I can understand why maybe historically that stuff hasn't always been focused on in motor speech disorders because it is like a very technical, like impairment based type of disorder. So I do appreciate that you put some efforts in to like talk about the whole communication. So can you talk about like when you're using this tool to set goals? What type of goals would you like to see an SLP maybe set be based on using this tool?
Yes, definitely, and I'm so glad you called that out because when I worked clinically, I feel like the emphasis was so much on intelligibility, and there's so many patients who are pretty intelligible, and yet their speech severely affects their quality of life, and so thinking about it beyond intelligibility, is their speech sound unnatural? Or they may be intelligible, but their rate of speech is so slow that it's inefficient and they're not really able to get their message out before somebody's walking away. And so, like you said, thinking holistically about, well, how do they perceive their speech? And then not just intelligibility, but is it natural sounding? Is it efficient? And I think so having that overall mindset of those goals and then looking at what features are affected. So if they have a pretty severe naturalness impairment, well, what's affected? Is it because they have impaired prosody? And you can look at how prosody is impaired. Maybe they have a hard time signaling stress. Maybe their pitch is really variable. And so looking at the features helps you develop an individualized goal for that patient instead of kind of a one size fits all approach.
That's great. So then can you this is kind of related, but can you share examples of how therapy time would be impacted then based on the results of the framework?
Yes, exactly. So I do feel like a lot of dysarthria treatments are kind of a one size fits all, loudness. There's a lot of loudness treatments.
Loudness, over
Yes,
articulation, like
please.
everyone just over articulate, right?
Yes. And you have workbooks that give you sentences for over articulation. And those are good for some clients, your hypokinetic clients, really for both of those goals, or flaccid dysarthria. But a lot of clients, their articulation may be fine or they're too loud already. We don't need a loudness goal. So I really appreciate the work by Dr. Kathy Yorkston, and she always emphasized a subsystem approach and an individualized treatment approach for dysarthria. So thinking what subsystems are affected, and within those subsystems, what features are impaired to target. So thinking, okay, how's their respiration? If it's impaired, what aspects of their speech are associated with that? Maybe it is vocal loudness. Maybe they have short phrases because they have such short breaths. They're not inhaling enough before talking that they can only say 2 words per breath. So, going from that approach gives you the ability to create individualized treatment targets for that patient. And also thinking about, okay, what features are really most significantly contributing to this person's dysarthria? Maybe they have like a really hoarse vocal quality, and that's the first thing to target, vocal quality. Versus articulation is so hard to treat in therapy. Maybe that's not even contributing as much to dysarthria as these other features.
Yep. That's good.
Mhm.
Um, the just kind of a funny question, but I could see people um, kind of like using the Colorado Motor Speech Framework and then like, okay, we did 8 weeks of therapy. Like
Mhm.
maybe I'll give this again. Do you see this being okay to like repeat, like at discharge or progress notes? Any issues with that?
Oh, 100%. You can definitely repeat it as many times as you want because, again, the essence of the tool is just a way to mark your observations of the person's speech. So, if you do the suggested tasks, what are they? They are connected speech. So, you're just having the person talk and you're observing their speech. Maximum phonation time. I don't know if somebody practices that, maybe they'll get better at it, but I don't think we're doing it that much in therapy that we expect practice to make that big of improvement, or DDK also. So these are typical tasks we're already doing like pre at the beginning of therapy and at the end of therapy. So the tool just gives you the ability to mark your observations of how their speech has changed. So yeah, you can use it as many times as you want throughout therapy, and say, "Oh, do I still hear that breathy vocal quality?" The only hard part, I would say, is for the clinician that we're not biased by our previous observations. So, if you already know that the patient started with a breathy vocal quality, really think, go into the CMSF evaluation thinking with a fresh mind, and try not to be biased by your former observations. But that's going to happen regardless if you use this tool or any tool for observing speech.
Yep. That makes sense. So it's really cool to hear like how much this has taken off in the last several years and like how you've kind of listened and adapted and changed it. So just curious, do you have any further projects that you're working on with this?
We have a lot of projects in mind. And again, we're getting emails a lot from people about, well, how accurate is the tool? How reliable is it? And I'm like, well, I guess those are all the things we need to be doing right now. I want to get it published in a peer reviewed journal. That way it can be cited. We are currently working on reliability, and I have tested a few people with motor speech impairments, and I'm going to send them out to SLPs and see how reliable for 2 things. One, how reliable is their diagnosis? So, do they all say this person is hypokinetic, or does one person say ataxic? And then, how reliable is feature identification? Did they all say this person had fast rate of speech, or not? So, those are the 2 reliability factors. So, we are working on that now. Um, I have a lot of ideas for the website. People have asked me for audio examples. So I am working on that too, having some audio examples where, what does syllable segmentation sound like? What does a breathy vocal quality sound like? Uh, Joseph Duffy in his textbook has an amazing set of video examples, video and audio examples. So I kind of picture an updated version of that with some newer patients. So just having examples again of these features and maybe even dysarthria subtypes, and people can kind of start to build their perceptual ear based off of that.
Yeah. Oh, man, that sounds amazing. It also doesn't sound like it's a side project anymore, so
Yeah, it has really taken off quite a
Oh,
bit.
that's
Yeah.
awesome. Okay, so right now, guess what time it is? It is the wild card question time. So here's your question. If your research lab had a mascot, what would it be and why?
Oh, good question. Okay. So if my research lab had a mascot, I would say I would say a parrot because I study prosody, so I'm interested in how speech is produced. And so, what is the pitch and the loudness and the timing and things like that. So having some mascot that also has, sings and talks and has actually quite interesting prosody. I would say, thinking of what animals have the
Yes.
most interesting sounds and songs, and I would say a bird, a parrot,
Love
so
it. That
that
sounds
matches well.
perfect. Okay. Good answer. That's a hard one to do on the spot. Okay. So this has been a really interesting discussion. So if we were just going to talk about maximum impact, what would be 3 actionable takeaways that you would want clinicians to put into practice?
Yes, definitely. So 3 actionable takeaways. The first one is something we've been talking about already, which is just documenting your perceptual observations is really important. So even if you don't feel confident in dysarthria diagnosis, even just the minimum of documenting what you're observing, how is the rate of speech, how's their vocal quality, that is really important. So going through what you're observing, writing that down, and you don't have to be 100% confident in what you're observing, but whatever, I would still note it and write down anything unusual. So I would say at minimum, documenting what you're observing is extremely helpful for both yourself, medical team, future SLPs, things like that. So that's the first takeaway. The second takeaway is that differential diagnosis can be really beneficial for the patient and their medical team. For example, I mostly work with people with spinal cerebellar ataxia, and really everyone I've talked to has a story of spending 10 years of their life going through different diagnoses. They were initially diagnosed with multiple sclerosis, then Parkinson's. And even though you can diagnose spinal cerebellar ataxia with a genetic test, it wasn't on the medical team's radar. And so if there was an SLP who noticed, oh, this patient has a clear ataxic dysarthria, well, they could have skipped over all those previous diagnoses and guided the neurologist to some sort of ataxic disease. So I do think differential diagnosis can have a huge impact. There's a lot of stories in which SLPs are the first person on the medical team to notice something, notice that there's impaired speech, or notice that speech doesn't match the neurological injury. So we are a really important part of the medical team, and we have this unique skill set of perceptual training. We need to use it, and it can be really beneficial. So that's the second takeaway, is that differential diagnosis is really important, and we have this unique skill. And then the third takeaway is that patients with dysarthria should have individualized goals. And, we already talked about how word drills or loudness programs are not appropriate for all clients. So documenting your observations and building your goals from there helps you develop personalized goals for your patient. And the personalized goals, that's what's going to help patients have effective therapy.
Yep. That's awesome advice. It feels like in another way you're saying like you can do this right now. Like even if you're like I'm not ready to call it a differential diagnosis. This tool helps you at least do the features and then once you get comfortable, like, be confident in the expertise we bring to the table. Like, the neurologist might need our input, even if it's different from what's been previously thought.
Exactly. And I'll say, again, we have this unique skill. Neurologists, brilliant, love working with neurologists, but they do not have this perceptual skill. I've seen sometimes they write observation of someone's speech. They'll say, "Oh, this patient stutters," and I'm like, "This patient doesn't stutter," you know. Um,
Yeah.
they're not, they're not trained with this perceptual ear of hearing those slight differences in speech across neurological diseases and conditions and neurological areas. So we have this very unique skill set that is extremely beneficial.
Yep. Awesome advice. So let's maybe talk through, just help the listeners apply this by talking through a couple hypothetical case
Yeah.
examples or maybe like a clinical win
Yes.
that you'd be willing to share.
Yeah, definitely. Okay, so as I mentioned, I work a lot with people with cerebellar disease, and so I'll kind of review that one first because I've heard this story a lot of times, and it's such a common experience. So again, you have somebody who's starting to experience some balance difficulties. Their speech is a little bit hard to produce. There's something going on. They go to their neurologist, and they first get diagnosed with multiple sclerosis. Then a couple years later, they revisit their neurologist. Okay, I don't think it's that. I think it's Parkinson's. And this is going over 10 years, and they're trying to get into their neurologist appointment and things like that. So, a motor speech evaluation could guide the neurology team to an ataxic dysarthria, which would narrow the diagnosis down to something cerebellar and help the medical team. So, the speech therapist might notice, oh, this patient has really variable prosody, variable pitch, variable loudness. They have some articulation errors, but they're irregular. So sometimes they produce it correctly, sometimes incorrectly. They have telescoping errors where their multisyllabic words get kind of mushed together, or some syllables just aren't produced as clearly. That's a classic sign. And then they do their oral mech exam, and everything's looking pretty normal, except they have some incoordination. And all that would lead you to an ataxic dysarthria. So that's one example of, again, it can really help with differential diagnosis. Um, Another example is a patient comes in, for example, they have a consistent history of Parkinson's. It's pretty clear they have Parkinson's. They respond to dopaminergic medication, but you notice some unusual characteristics that do not align with hypokinetic dysarthria. Maybe they have a strained vocal quality. And their oral mech exam, they have a slight drooping on one side of their face, and maybe their speech is a lot slower. So some things that just don't align with the hypokinetic. Give these observations to the neurologist. They do an MRI. They find out that the patient had a stroke, and they would not have found that if you were not the person who alerted the medical team. So, and maybe I can give one more example.
Oh, absolutely. Yeah.
Perfect. Another example is, a patient comes in, maybe like a younger patient, and they're complaining that when they talk a lot, their speech gets really hard to produce and people have a hard time understanding them. They have to go home, they take a nap, and they can talk better. Maybe the neurologist, they think, oh, those symptoms are kind of unusual, and they get diagnosed with a functional disorder, functional movement disorder. Um, and then that gets in their medical chart. They have a functional movement disorder. Every time they go in, people are saying, "Oh, it's a functional movement disorder. It's not. There's nothing organic." Well, the SLP does an assessment and, does stress testing, for example, maybe has them read for like 20 minutes at a time with really enhanced articulation, notices how much their speech is impaired, lets them rest for 10 minutes. They talk again, their speech improves, and they realize this is actually pretty consistent with the flaccid dysarthria from myasthenia gravis. Obviously, we can't diagnose myasthenia gravis, but we're noticing, though, the considerable deterioration of speech. We alert the medical team, and they realize it's not a functional movement disorder. It is actually myasthenia gravis. Patient gets on medication, and the condition improves. So it's a lot of situations where our observations can really improve a patient's quality of life.
Absolutely. And yeah, just to kind of go back to the tool, like I think we can feel confident by kind of like aligning like what patterns we're seeing and not just like, oh, I don't know, that seems a little different, but whatever, like this is the tool
Exactly.
that we need to kind of help us be confident in explaining this. So
Exactly. And I will say you don't have to be 100% confident in what you're observing either. That's a big thing that Joseph Duffy emphasizes in his work is actually our level of confidence is another important indicator. So you could say, patient has pretty clear, fast rate of speech and breathy vocal quality. I think, they potentially have imprecise articulation, or they potentially have this. Um, there's a clear hypokinetic dysarthria, but maybe a mixed ataxic component. You don't have to be 100% confident in everything. Even those observations that you're not as confident in are still beneficial.
that's awesome. That is really important for all of us to hear. So thank you so much for being here today. As we wrap things up, do you have any final like words of wisdom or
Yeah,
inspiration that you want to leave with the audience?
definitely. I would say this is hard. I think a lot of SLPs really dread dysarthria diagnosis because it's hard. There's a lot of weird patient presentations. A lot of things are complicated. And then when you get into mixed dysarthria, people really freak out. And I would say, you do not have to be 100% confident in what you are diagnosing. Just be honest with what you're observing and write that down. If you're not totally confident in doing a mixed dysarthria diagnosis, you could just say, well, I, I'm pretty clear that this patient has a spastic dysarthria, but I'm noticing some other features that don't always match. And you could just write those down. So just being honest with what you're observing, writing them down, at that minimum, that is extremely helpful.
Yes.
It'd actually be more detrimental if people were overly confident all the time. I'm for sure that this patient has a mixed spastic hypokinetic. That may not be truthful.
Yes.
So just being honest with what you're observing and how confident you are in those diagnoses is incredibly beneficial. So, that's my advice, my takeaway, words of wisdom is you have unique perceptual skills. Just sit back, listen to the patient, think about what you're observing, and be honest with those observations. And you're doing really great clinical work.
Thank you so much. I am so happy we could learn about the work that you've done and thank you from all of us. This is a very helpful tool. So thank you, Allison Hilger, for the insight and the clinical takeaways related to assessment in motor speech disorders and your ongoing work with the Colorado Motor Speech Framework.
Thank you so much for having me. I had a lot of fun today.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.